Hi, my name is Maggie Shearer, and in this presentation, I'm going to be discussing prone positioning and the ArdsNet protocol. Some learning points of this presentation, I will be discussing pulmonary circulation, what ARDS and the ArdsNet protocol are, and I will end with explaining the prone positioning procedure. So first, I want to talk about the process of pulmonary circulation. Pulmonary circulation is the distribution of blood flow from the right ventricle, where the blood starts as deoxygenated blood. It then travels out the pulmonary arteries and goes to the lungs to pick up oxygen, and then travels back to the heart through the pulmonary veins and into the left atrium, where the blood now is oxygenated and has the ability to travel to the rest of the body and send oxygenated blood to the tissues. So, what is ARDS? ARDS stands for Acute Respiratory Distress Syndrome. It is a severe and life threatening lung condition. It can be caused by either direct or indirect lung injury, most commonly sepsis and pneumonia, but there are a lot of other factors. It can be caused by aspiration, chest trauma, burns to the chest, any of those things, but we will dive into that more later. ARDS is a process that causes low oxygen saturation, rapid and shallow breathing, and even in the most severe cases can cause multiple organ failure. Now let's talk about prone positioning. Prone positioning is a therapeutic medical technique commonly seen in intensive care in patients with severe lung injuries such as ARDS. It also was really common with COVID patients. It involves lying a patient flat on their stomach to help improve oxygenation. It also improves ventilation and makes breathing easier by relieving pressure on the lungs. And this in turn helps open up collapsed alveoli. So, the distribution of pulmonary blood flow. Blood flow in the lungs themselves is unevenly distributed. This is because of gravity. So, blood flow will increase from the apex, which is the top of the lungs, to the base, which is the bottom of the lungs. I have a picture in the next slide that will help to visualize this a little bit better. So, here we see pulmonary blood flow being broken down into zones 1, 2, and 3. As you'll see on the picture on the right, zone 1 is going to be a period of little to no blood flow at all, and then as gravity works its force, we'll move to zone 2, where you'll see a moderate amount of blood flow, moving down to zone 3, which is going to be the point of highest level of blood flow. This is where perfusion is at its highest. So, where does pulmonary vascular resistance play a role in pulmonary blood flow, and how are they related? Let's start by asking ourselves, what is pulmonary vascular resistance? This is the resistance that the right ventricle must overcome to push blood through the lungs by way of pulmonary circulation. Pulmonary blood flow and pulmonary vascular resistance are going to be inversely proportional to each other, which means that when pulmonary blood flow increases, this could be during high levels of activity such as exercise. Pulmonary vascular resistance is going to decrease during those times to accommodate for the extra blood that is being pumped without causing an increase in pressure. And below we have the equation for pulmonary vascular resistance. It's going to be equal to the mean pulmonary artery pressure minus the pulmonary capillary wedge pressure divided by cardiac output times 80 dynes. And for a normal healthy adult, the normal value for pulmonary vascular resistance is anywhere between 24 to 160 dynes per second per centimeter. So, in talking about pulmonary vascular resistance, it's also important to include Boyce-Way's law. This law states that pulmonary vascular resistance is directly proportional to blood viscosity and vessel length, but is inversely proportional to the radius. To put this in simple terms, it just means that if you have a vessel that is smaller in size, blood viscosity is going to be much higher, causing more resistance to flow. This also implies, on the other hand, that if you have a vessel that is much larger, blood viscosity is going to be lower, causing little to no resistance in flow. And a 50% reduction in radius increases resistance by 16. And below, we have the calculation for Boyce-Way's law, which just states that resistance is equal to 8 times the viscosity divided by pi times radius to the fourth. Now let's talk about the determinants of cardiac output. First off, what is cardiac output? It's the volume of blood that is pumped by the heart per minute. And cardiac output is determined by two factors, heart rate and stroke volume. We know that heart rate is the number of times that a heart beats per minute, but what is stroke volume? That's going to be the volume of blood that is pumped per beat. To dive a little bit deeper into stroke volume, that's going to be further influenced by three different factors: ventricular preload, ventricular afterload, and myocardial contractility. Ventricular preload is the degree of stretch at the end of diastole. Diastole also is known as the filling period, where the heart is filling up with blood. Ventricular afterload is the resistance that the ventricles must overcome to eject that blood. And myocardial contractility is the force of the heart muscle contraction independent of preload.